Center on Addiction and Behavior Change. And before I introduce today's speaker, I just wanted to have a little look ahead. Is that on February 9th is going to be our next seminar. It's going to be live in person at the DIBS facility. It won't be online, but we're going to have Joyce Bashir from University of North Carolina, Chapel Hill, talk about the interaction between stress and drinking in an animal model, relevance for PTSD. And then we're going to go on and have February 23rd, Samuel Centani from Wake Forest University talking about the role of the insular cortex and stress response and alcohol, so similar theme. And then go on through the semester. The only other online one we have is Wendy Lynch is going to be on March 30th, but the rest are going to be live. So please come to the DIBS facility on campus. They will be recorded, and if you can't make it for the live presentations, you'll be able to go to the CABC site on the DIBS website and to look at them recorded. So today it's my privilege to introduce a friend and collaborator and fellow faculty member here at Duke, Dr. James Davis, who is the medical director of the Duke Center for Smoking Cessation. He's done just a fabulous job really bringing that on in a big way, and he'll speak about that some today. And the director of the Duke Smoking Cessation Program. And he's been here for how many years now, Dave?
Well, eight years, I think, something like that. It's starting to grow, yeah.
Yeah, so he's an old Duke hand at this point, not as long as elderly folk like myself, but he is certainly well established here. And today he's going to be talking to us about tobacco use pharmacotherapy, innovative approaches to real world situations. James?
Great. Thanks so much, Ed. And so I kind of went back and forth on what might be interesting to this group, and I feel like most people in this group are very engaged in very I don't want to say basic science, but very foundational science that leads to specific therapies and therapeutic approaches or new understandings of tobacco use, toxicity of tobacco. And I wanted to kind of step back to a bit of a higher level and talk about what kind of how clinicians are making sense of the existing research and turning that into practice. And I'm speaking from the perspective of a specialized treatment facility, and so we're kind of ahead of the game, by a few years, but kind of what do clinicians do with the data that exists, and how are we putting that into practice, and specifically with pharmacotherapies. And please feel free to jump in along the way. I'm happy to address questions. A lot of what we'll be discussing here is efficacy. How effective are particular treatments? And if you're not doing clinical work, then, most of us know this, but if I don't say what a specific, efficacy criteria was used, I'm typically referring to 6-month post-quit biochemically verified smoking abstinence, and we're either using 30-day or 7-day self-report, and then biochemical verification with either carbon monoxide breath testing or cotinine testing. And those are the kinds of standards that we're typically using here. We're not really talking about studies that don't have biochemical verification. The first thing I want to look at is an overview of the FDA-approved medications in a meta-analysis that was run by Kate Cahill with the Cochrane group. This was back in 2013. This included over 100,000 participants in all, multiple randomized controlled trials. And there were some fairly important findings that came out with this large meta-analysis. And what it showed is that there were two types of treatment: varenicline as a monotherapy, and then patch plus gum, lozenge, or inhaler, one of the immediate release therapies. Just those, the nasal spray wasn't assessed in a meaningful way. Those two therapeutic approaches really stood out as being more effective than the others. The other monotherapies, we're looking at relative risks versus placebo, and I should say these are all placebo-controlled, randomized controlled trials, so we have a reference to placebo. And we're looking at relative risks. If you consider placebo at 10%, you're looking at abstinence rates between 16, 17, 18, 19%, right in that range for all of these monotherapies, except for varenicline, and that's running around 24%, and then combination NRT is running on 23%. There was no statistically significant difference between varenicline and combination NRT in that particular study. Actually, John Ebert ran a secondary analysis that was a little more sophisticated, and it showed that varenicline had a bit of an edge over combination NRT. And then there was another study that was done that actually showed a slight edge for combination NRT, which I thought was less compelling. But this has led clinicians to lean into either varenicline or combination NRT really as a standard of care, really to say we shouldn't be prescribing nicotine patch by itself, nicotine gum by itself, bupropion by itself. At a minimum, we should be trying to prescribe these most effective therapies. That doesn't always happen. There are all kinds of constraints and other considerations that come up. But if you're just considering efficacy, those are the treatments that we tend to lean toward. Now, I want to describe a little bit from a clinician standpoint how we make the decision to use varenicline versus combination NRT or one of these other therapies, because they do come up. So reasons for using varenicline. One reason for using varenicline is we occasionally have patients that are very high level nicotine dependent, have very high level nicotine dependence, or they're very heavy smokers, and they actually, and we're going to use varenicline combinations. That's varenicline bupropion or varenicline patch, and they seem to be very effective, especially varenicline bupropion in those high dependence smokers. And Jed Rose has a wonderful study that showed that. John Ebert had another study that showed that, where a sub-analysis in high dependent smokers was really driving the effect that we saw when we added varenicline bupropion together. I can tell you from my own experience, when I have varenicline on board with a very high dependent smoker, oftentimes it doesn't control withdrawal symptoms. And when I add bupropion to that, we get good control of withdrawal symptoms. You hear the stories. You hear people say, yes, I feel like I'm finally getting control of my symptoms, and now I'm able to move forward. And so there's kind of a human side that you get that I get as a clinician that is sometimes very helpful in putting together kind of why the research is saying what it is. Another interesting group is people who are light and intermittent smokers. These are people who smoke less than 10 cigarettes a day. They tend to be primarily driven to smoke, not by withdrawal symptoms, but by cues in their environment. That tends to be the primary driver of smoking. And if withdrawal symptoms are not a major driver, it should make sense that medications like nicotine patch and bupropion, whose primary effect is to decrease withdrawal symptoms, that those medications might not be very effective in this group. Whereas varenicline, which is blocking nicotinic receptors and blocking nicotinic reward, would in fact be effective at decreasing cue response. When you don't get reward, then that doesn't then you don't have reinforcement for your cues, and cues begin to extinguish. And this is a theoretical basis, but what in fact we see is when we use nicotine patch or bupropion, or even there's Schiffman did a nice study looking at lozenges in cue-based smokers, did not show much effect. Bupropion hasn't shown much effect. And then Ebert did a study with varenicline and cue-based smokers and light intermittent smokers, really nice large effects. I'm not going to go into all of this, but that's another group where we're going to see varenicline used very, very helpful. People who are using or smoking and using a significant amount of alcohol as well. And of course, alcohol use and smoking are very tightly related behaviorally and also biochemically in the brain, where you have alcohol decreasing thresholds to cues and cue response. And varenicline decreases alcohol use, and it decreases the craving for alcohol. We actually see alcohol use drop almost in half in people and who are just using alcohol. And this is a very nice treatment for smoking cessation in people who are using alcohol. Chewing tobacco is another one. Nice study by John Ebert on that. And then the other situation that comes up a lot for us is surgical cases. We run a perioperative medicine service at the hospital, and the surgeons often don't want nicotine around, and that's really because of these. There's some mouse studies and rabbit studies where they're looking at decreased flap closure. Mostly they were using very large doses of nicotine with high serum concentrations of nicotine in the animals, but it's made surgeons very hesitant about having nicotine around, especially with orthopedic studies because of bone healing and also with large flap closures. We're often using varenicline in the hospital because of that, so that we're not running into those patients, into those problems. So a number of reasons, again, why clinicians are leaning toward varenicline, that and the fact that it's just very effective. So what about combination NRT? So one of the clinical kind of foundationals, one of the clinical tenets of using combination NRT effectively is that there are patients who really like nicotine gum and lozenge and they really use them, and there are other people who really don't. And you can try to ferret this out in a conversation with a patient. But if you don't have somebody who's a gum chewer or a lozenge sucker, then they're not going to be using these medications. And adherence with nicotine gum lozenge inhaler is the worst of all adherence for any of these medications. If they don't use the medication, it's not going to be effective for them. So that's really important. If you find a patient who really does chew gum and lozenge and they like those, then these kinds of treatments tend to be very effective. We also have to train people in how to use them, because if they just chew them up or suck on them, then they'll get a lot of nicotine in their stomach and they feel sick. So it needs to be absorbed into their cheek and gum. They need training in how to do that. This is nice for decreasing side effects. It's nice for patients who have kind of complex medication regimens, and we don't want to add varenicline or worry about side effects. It's also very commonly used in pregnant patients who failed behavioral treatment. We move on to nicotine replacement therapy and people in the hospital. There are good reasons for using bupropion. The number one reason by far is that it's covered by Medicare. As many of you might know, nicotine replacement is not covered by Medicare. It's considered over-the-counter, and Medicare won't cover over-the-counter drugs. Varenicline actually is covered by Medicare, but the copay is so high. For many of my patients, it's right around $300 per month, which is cost prohibitive. And so we end up being required to use bupropion in Medicare patients because neither nicotine replacement nor varenicline is really an option. You can get it over the counter for $9 a month at Walmart. That just went up to $12 a month, I think. It also suppresses appetite somewhat, and it helps a little with post-cessation weight gain. Won't go into that in detail here. Leads to some decrease in depression symptoms. And I won't go into the nuance. There are some reasons for using clonidine. We tend to shy away from clonidine with some patients. Patients who are using opioids, clonidine will actually enhance the euphoric response to opioids. And so we get a little nervous about using clonidine in some patients who are on opioids. But if a patient has bad agitation or anxiety during withdrawal, and that seems to be really getting in the way of them quitting, then clonidine really helps. And to be clear, the other medications that we're giving, nicotine replacement, bupropion, varenicline, all of those medications increase norepinephrine levels, and it can make agitation or anxiety worse. Bupropion tends to be the worst among those. It gives you a big norepinephrine hit. and can really make anxiety and agitation much worse. So we will often see that. Well, we can have somebody with bad anxiety or agitation, and we put them on drugs, and we get a paradoxic effect. They actually get more agitated on these drugs, and then that's a good reason to switch to clonidine. I typically only use this after something else has failed, though. And it will decrease blood pressure. What about nortriptyline? Don't use this much. No one really uses it much, but it does help people sleep. The other medications are going to keep people awake and are going to be stimulating. There's a handful of patients that really smoke through the night, and they're up all night, and that's kind of their thing. And this is a really nice medication for those. If you find that and this can be a paradoxic effect, you'll put somebody on nicotine patch or varenicline or bupropion, and they'll be more awake at night, and so they'll smoke more, and you'll get a funny paradoxic effect from your medications. And that's the time to use nortriptyline. So kind of clinical decision making. It's very common to use long-acting and short-acting medications together. This is relatively, we don't have studies on all of these, but we have good studies on using nicotine, long-acting nicotine replacement. But in fact, you can use varenicline together with nicotine gum or lozenge. This is commonly done in every program around the US, that everybody that I talk to, we do it here. And there's an intuitive approach here, and that is that the immediate release nicotine tends to provide some relief for urges that arise more spontaneously throughout the day, where a person is having kind of an acute syndrome and needs some coverage acutely. And so there's kind of an intuitive, there should be kind of an intuitive understanding. So what about non-FDA approved approaches to tobacco treatment? That's what I want to get into a little bit today. First thing I want to look at is changing the dose of the medication, not using the standard dose. The other is starting the medications early before the quit day. And again, the standard is to either start on the quit day, which is the standard for nicotine replacement, or 1 week before, which is the standard for bupropion and varenicline. Adaptive treatment, which is really assessing a treatment response during the pre-cessation period, using medications before the quit day, just like we're saying above, but then assessing what's going on with a medication in response to that medication, and then changing the medication regimen if somebody's not responding to the medication. And that's kind of a very broad way of thinking about adaptive treatment. And that was really, Jed Rose and Ed and I have all been working on adaptive treatment for a little while here at Duke. Increasing the length of treatment. The standard that's been approved by the FDA is 12 weeks for most of these drugs. We're now looking at doubling that, going out to, well, it's technically 24 weeks, but many of these studies go out to 26. And then the others, combining medications. We've looked at combining nicotine replacement medications, but what about combining the varenicline with other medications? So let's jump into some of these studies. Nicotine matching. This is really the question of dose, of what kind of dose do we use with nicotine patch. The recommended patch dosing is 21 milligrams for 11 to 20 cigarettes per day. And with nicotine matching, what we're looking at is going up to 42 milligrams for 2 packs a day. That's the limit for most of the studies that have been done on this, though there are studies where they're using much higher doses of nicotine. And we know clinicians who go up to 6 patches a day is very impressively high patch doses, and you simply titrate it up slowly, and you do it based on patient symptoms and based on patient's response. So you don't slap 6 patches on somebody right away, but if you dial up slowly and you assess symptoms, they're tolerating it well, then that makes sense. There was a lot of these studies, almost all of these studies have been underpowered. There was a meta-analysis done looking at 10 of these trials. Most of them include the 42 milligram dosing. And it looked like it had slightly higher abstinence rates than the 21 milligram patch, with relative risks in the 1.2 to 1.4 range. None of these were statistically significant. My guess is that it probably is better to use these higher doses of patches for people who are and I'll tell you clinically what actually happens is when I put somebody on a 21 milligram patch and we don't see control of symptoms, we don't see control of withdrawal symptoms, they're still having lots of urges and withdrawal symptoms, then we increase the dose. And that's just, and so that's that's kind of the way this is done in the real world, is that if you're not getting good control of symptoms, you dial it up. So what about low dose varenicline? We were talking about high dose patch, and low dose patch has been accepted for a while for people who smoke less. Low dose varenicline is a really interesting topic. And the reason it's so interesting is that varenicline has a high incidence of side effects. And many clinicians and many patients are concerned about varenicline and physicians don't want to prescribe it. Patients don't want to take it because of the side effects. Now, and that's even without even if you accept the Eagles trial as, as a definitive kind of proof that we don't, have significant, moderate to severe neuropsychiatric effects, which is what the Eagles trial was looking at. Varenicline is still problematic due to side effects. Low dose varenicline actually looks very interesting. If you go back to the initial dose finding studies, the phase 2 studies that was done by Pfizer for their 2006 application. And this was the phase 2 studies in 2004, and it compared half dose varenicline with full dose varenicline. So its standard dose is 1 milligram twice a day, half dose is 0.5 milligrams today. What they saw is about a 20% reduction in abstinence rates with the half dose, but almost a 50% reduction in side effects. It's interesting that then they decided to go with the 1 milligram BID. And I think what probably was happening is that it was very important for them to make a marketing claim of superiority against bupropion, which is what the comparative trials, the 2006 comparative trials were against bupropion. And I don't think I think it was really important that to Pfizer that they got that. And so they went with the higher dose. But we ended up with a medication that really has a pretty high incidence of side effects. And most of this is nausea and sleep problems are the big ones, though you do get a portion of people with a psychiatric syndrome as well. Faust-Rosen ran a really nice study comparing in 2017, comparing varenicline 1 BID with 0.5 BID, showed essentially identical abstinence rates that are shown here, 46.5 versus 45.4% abstinence rates out at a year, very high rates out at a year, with a very large reduction in side effects. Now, the way that this was run, it was not statistically significant, the reduction in side effects, but it's consistent with a body of literature now that shows that there are, that side effects are less common in the lower dose. A Cochrane meta-analysis showed 25% higher abstinence in standard dose varenicline. That sounds about right based on my experience. And that just failed to reach significance, p-value of 0.05. Again, I'm convinced that the standard dose is probably a little more effective. We ran a case series here at Duke where we looked at 22 smokers who had all failed varenicline treatment because of side effects. And almost all of these were either sleep problems or nausea. And then we started them on low dose varenicline. 20 of the 22 tolerated it and continued on treatment. And so that shows us that, in fact, dose reduction really is meaningful with varenicline, that you really are able to tolerate it with dose reduction. And then we had a very nice, out at 6 months, we had a biochemically confirmed abstinence rate of 36%. So very kind of nice little study. That was run as an observational study, so it's not a randomized control trial or any. It's lower level of evidence, but I think it points in a nice direction. My take home on this is that we should be using low dose varenicline in probably a lot of patients. That a lot of patients really do tolerate it better, and that it tends to be quite effective in a lot of people. And so I often will just start with low dose varenicline and then increase if it looks like I don't have a therapeutic response. If they're tolerating, well, we don't have a therapeutic response. You can go either way, or you can start with full dose and then back down. But I think that's something that we should be using a lot. To move on, low dose bupropion, this doesn't come up that much, and it's not a game changer the way low dose varenicline is for us at the Duke program. Low dose bupropion shows up because people can't sleep when they take that second dose of bupropion. And so the question is, what if you put somebody on 150 milligrams SR twice a day, then they can't sleep? Can you get rid of that second dose of bupropion and still have an effective therapy? This is an old study from Richard Hurt at Mayo, and back in, I don't know, 79 or something like this, back in the day, but essentially showed almost equivalent abstinence rates for low dose bupropion and standard dose bupropion. I don't know if I want to bank on a single study like this. There haven't been exhaustive or extensive studies on this, but it's been my experience that when I remove that second dose of bupropion in the evening, people tend to do pretty well. And so that's just kind of a thought. I think that that's a reasonable response to somebody who is not tolerating bupropion due to sleep problems. You get rid of the evening dose, sleep problems go away very quickly and well, and you still have an effective medication. Okay, on to the Jed Rose study and from 2009. This is 2-week pre-quit nicotine patch. So Jed ran this study showing a very impressive response using 2 weeks of pre-quit nicotine patch versus starting nicotine patch, right on the quit day. 6-month abstinence was like around 14% versus 7%. It was statistically significant. If you look at 10 weeks post-quit, the differences were quite large. It was about 33% versus like 10%. It was for the standard patch. So very nice differentiation. That was then followed up by a study that did not show much difference with pre-cessation nicotine patch, where we had pre-cessation patch at 21%, 22.7%, and then starting patch on the quit day at 21%. And that was found to be non-significant. A meta-analysis that included both of those studies, and I think another small one, showed that there was about a 25% increase in efficacy favoring pre-quit nicotine patch, and it was significant. Our take on this is that it's probably better to start nicotine patch early before the quit day. And as we look at the other medications, we see a trend. We see that for most of these medications, it looks like starting early is better. And then that also opens the door for adaptive treatment, which we'll talk about it in a second. So what about bupropion, pre-quit use of bupropion? The studies here were done on 4-week pre-quit bupropion. It makes me wonder, there hasn't been a lot of study on 4-week pre-quit nicotine patch. And I think that that's probably, we'll get a pretty robust effect from that. But the 4-week pre-quit bupropion, here we had people who were starting 1 week before the quit day, which is the standard treatment, versus 4 weeks before the quit day. And a pretty large difference here in abstinence rates. So, 53% versus 31%, that was significant. That was a study by Hawk in 2015. That has been enough for us in the program to say, yes, let's start bupropion early. There was another study as well that I'm just not citing here. 4-week pre-quit varenicline showed something very similar, where we have this is 12-week post-quit abstinence rates of 47% with 4-week pre-quit varenicline versus 1-week pre-quit varenicline, which was 20% abstinence rates, highly significant. The FDA went on and approved a pre-quit varenicline out to 5 weeks. And that included, there was another study that looked at 6 months. That was done by John Ebert also, that other study looking at 6 months pre-quit varenicline. which I'd find it very difficult to have my patients adhere to that much pre-quit medication, but but that's what they did. So that was actually FDA approved, that approach, and I think there's very strong support for that. So again, at this point, before getting into adaptive treatment, it looks to me like there is support for pre-quit, for 2 weeks pre-quit patch, and 4 weeks pre-quit bupropion, 4 weeks pre-quit varenicline. And now what about adaptive treatment? So the first kind of thing to understand with adaptive treatment is that we're talking about when a person makes a quit attempt, there's this process of getting all your life force together and all of your willpower and making a very foundational behavior change in your life. There's this very challenging transition that you're facing. And if you're on a medication that's not very effective and you're trying to do this and the whole thing kind of crashes and burns, it's very difficult, it's demoralizing, and it can be a while before you can kind of pick up the pieces and make another run at this. And that's just kind of human nature that I'm describing, not studies. What the idea with adaptive treatment is let's get the medications right before someone actually tries to quit smoking, so we don't have them crashing and burning and then having to pick up the pieces later. Let's dial in the medications and get them effective, get a real physiologic response from these medications before they try to quit. So let's look at some research. Responders versus non-responders. So first of all, to pre-quit treatment, to treatment in that pre-cessation period. So what does a responder mean? What's a responder? Responder's been defined as having over 50% reduction in smoking after 2 weeks on treatment. And there have been some slight changes. I ran a study where it was 50% or more. It's very slight, very slight change. But initially over 50% pre-quit smoking reduction after 2 weeks on treatment. The idea here, and you're actually saying to you're not telling you're telling your participants, you're telling your smokers, smoke as usual. We don't want to see the effects of willpower. What we're really looking for is a physiologic effect to treatment. We want to see if the medications are really having an effect, then people should be smoking less. And the most sensitive assessment is looking at carbon monoxide testing, because that's going to include cigarettes per day. But also, if people are on an effective medication, they won't be inhaling as deeply. They won't be smoking as many puffs off of each cigarette. The smoking topography is going to change, as well as the number of cigarettes per day. So we'll get that in carbon monoxide testing. For clinical purposes, because we're not always assessing in the clinic, we're not always doing CO testing. We're using cigarettes per day, and it tends to be pretty close, not exact, but pretty close. So again, over 50% pre-quit smoking reduction after 2 weeks of treatment. When Hayek did a study in 2011, he found that people who were responders on varenicline had an abstinence rate of 66%. I think this was out at 12 weeks. 66%. People who were non-responders in the pre-quit period had an abstinence rate of 22%. This means that we have a really good idea of who's going to be successful after they quit, 12 weeks after they quit, by what happens 2 weeks after they're on this treatment. And that's really important. We're able to forecast the future now based on what we see early on in treatment. Again, responders showed a 3-fold increase in smoking abstinence here. Nicotine patch, a study by Jedros showed that responders had a 42% abstinence rate. Post-quit versus non-responders had a 7% abstinence rate. That's a 6-fold increase. There was actually another study that was done that looked at something similar, and it showed about a 3-fold response. And so I don't necessarily, I'm not that convinced of a six-fold response, but I am convinced that there's a real difference in the abstinence rate of responders and non-responders in the pre-quit period for these patients. So what is adaptive treatment? Adaptive, the core idea is we start a medication, we assess whether or not people are responding to that medication by the decrease in smoking. And then if they're not responding, if they're non-responders, we're going to add something to that treatment. And right now what we're adding is bupropion, but we'll see as the science of adaptive treatment evolves, whether we're going to add other things or do other things that kind of fit within that general motif of adaptive treatment. So I want to share. This is a study that we just completed. Ed, I don't know if you've seen this yet, and Jed and I are going to be submitting this. But here we actually have people who are allowed to choose. The idea is to create kind of a naturalistic setting where they're allowed to be involved in choosing whether or not they're on varenicline or patch, which is very similar to the way things work in real life. The clinician talks to them about these medications and they go, oh, I'd really like, let's do this one. That one's the one, you get some buy-in and you go with that medication. And then we randomize to either adaptive treatment or non-adaptive treatment. And then we see kind of how people do. When we looked at everyone together, regardless of whether they chose varenicline or patch, we had a 30% abstinence. This is out at 12 weeks, 30% abstinence rate in adaptive treatment, 9% abstinence in standard treatment. So really big and very, very significant. When we looked at people who specifically chose varenicline versus standard treatment, that's looked like that's what was really driving the effect. Mostly it was 35.9% versus 9.5%, again statistically significant. Nicotine patch versus standard did not show quite as large of effect. Still about about effect size of 2, so pretty nice, pretty nice, but it was not the sub-analysis of that group was not statistically significant. So some nice data that we've just kind of put together to support that kind of treatment approach. I want to go on to talk about a couple of other things that are developing in terms of pharmacotherapy. One is extended treatment, treating past that 12-week period. Here's extended treatment with nicotine patch. Looks like 24 weeks of treatment. Again, we're getting out to 6 months versus 8 weeks is more effective. I'll move more quickly so that we can get through to some questions and discussion. But extended treatment with bupropion is the same thing. This was a study done a little differently for people who quit at 7 weeks. Some of them received bupropion for the rest of the year, and others received placebo for the rest of the year. And that showed a nice statistically significant improvement for the extended bupropion. And then varenicline was the same thing. The longer you keep varenicline going, 6 weeks, you get 16% abstinence rate. The abstinence rate's tested at 24 weeks. At 12 weeks, you get 23%. 24 weeks, you're up to 44%. So the longer you keep the varenicline going, the higher the abstinence rates. Here's combination varenicline bupropion. The study that was run, the study that Jed ran here, first it showed, initially it showed a statistically significant improvement of adding varenicline and bupropion compared to varenicline by itself. On a secondary analysis, what it showed is that effect was primarily driven by high dependence smokers and heavy smokers or heavy smokers and actually male smokers, which I haven't put this in, but that was, and then John Ebert up at Mayo ran a similar, looked at a similar treatment comparison, and it looks like those results were also primarily driven by high dependence and heavy smokers. So this has started to be very interesting to me, and we started using this kind of varenicline plus bupropion treatment in our high dependence and heavy smokers. And I'll just share kind of experientially that it's absolutely a game changer when you have very high dependent smokers, people who are waking up in the middle of the night to smoke a cigarette, people who are, have severe withdrawal symptoms. This is it's very helpful to add something to varenicline. Varenicline doesn't do a great job at managing withdrawal symptoms, though and when you bring in something like bupropion, it really does much better in that group. Varenicline and patch, we've seen similar kind of findings, but there haven't been the sub-analyses looking at separating out those high dependent smokers. My guess is we're getting the same kind of we're getting effects for the same reasons, but we just haven't seen those analyses. So this is just a table kind of looking at all of these different comparisons. I wanted to try to get through quickly so that we have a little time for questions and thoughts.
Okay, well, thanks, James. That was just marvelous in terms of your clinical experience and also your research experience, bringing that all together. And we do have some time for some questions. Murray had a question in the chat here. Was one NRT plus bupropion included? Or Murray, if you want to unmute, you can bring it up.
Sure, yeah, I put that in very early and just as you were going through sort of laying things out from the beginning, because that's also something, that combination, we advocate basically for any kind of combination and work in the VA. And I was curious if that has been downgraded in your view and its value.
Yeah. So it's a great question. So Doug Jornby ran a study, I don't know, it was probably 15 years ago now, looking at combining patch and bupropion. It didn't show much difference. And I don't remember if the comparator was patch or was bupropion. Somebody on the call might know that study, but that has made me a little less kind of impressed with adding that. That said, if you look at Jed's studies where he's adding bupropion to patch non-responders, then there is obviously a group of people where that makes a difference. And so I've kind of been, I tend to, maybe I'm superstitious, but I tend to use it, add it as an adaptive treatment as opposed to adding it up front.
Right. James, I actually, I think the study that you're talking about actually was one of those studies with like a p-value of 0.051 or something. So, and the control group was nicotine patch alone. And so, technically was not a significant effect of adding bupropion, but I do know, some of our friends and colleagues who are leading clinicians in the field, from I think from David Sachs to others, do often use bupropion in combination with NRT clinically. So I think there is that belief, and I think you may have hit the nail on the head, is that we've already shown that there is a subpopulation of non-responders for whom it is going to benefit. So the question of whether you just want to give it across the board or wait and see who those non-responders are, assuming you can quickly identify them before their quit date, and that is the key part of adaptive therapy, is you don't wait for them to fail. You actually can predict likely failure before it happens and intervene before that failed quit attempt, and then administer it after you have some indication of that. That's the kind of the judgment to make. But you did a beautiful job of outlining the philosophy behind the adaptive approach and reviewing efficacy. The one question I would have is you didn't, and there's only room to talk about so much, but it might be worth at least mentioning, because there has been a very recent Cochrane review on the efficacy of electronic cigarettes for cessation. Do you want to comment at least a little bit on how that fits into the overall picture? Yeah,
I think it's interesting, and I did kind of keep it to FDA approved and secondary treatments, second line treatments, but when comparing the largest study looking at e-cigarettes as a treatment for smoking was a study by Hayek that actually showed very impressive outcomes. It showed 18% versus 10% abstinence out at a year, I think. And so almost double the abstinence rate for e-cigarettes as for nicotine replacement. They actually were allowing patients in that study to use combination nicotine replacement therapy. The Cochrane review then came out and combined several randomized control trials and came out with a relative risk of 1.7, comparing e-cigarettes with nicotine replacement therapies. So it looks like e-cigarettes are in fact more effective than nicotine replacement therapies. The catch to this, and it was well shown in the Hayek study, is that about 80% of the people out at a year who had transitioned to an e-cigarette were still using that e-cigarette out at a year. Now, some people would look at that data and say, uh-oh, that means they're addicted to e-cigarettes. All we've done is transitioned them to another addictive substance, and the harms of e-cigarettes. Sven is deeply knowledgeable as one of our national experts on the harms of e-cigarettes. The harms of e-cigarettes make that a non-valid treatment. Others would say, actually, that's a very, it's very helpful for them to stay on treatment of some kind, because it might decrease the risk of relapse in the future. And so, or, there are other arguments that are made, or maybe this is for special populations for whom other treatments have not been effective. There's a lot of commentary and thoughts about this, but the efficacy is impressive. The efficacy stands, alone.
Yeah, and just to add to that, I think that the strength of e-cigarettes is the long-term efficacy, because there was a great paper that I wish I could remember the author's name, but in the last year, looking at the public health impact of short-term pharmacotherapies for smoking cessation, which we spend most of my career, most of your career on. And the problem is that and you summarized this accurately, that the short-term success rates at the end of treatment, which can be as high as 50% with a treatment like varenicline, dwindle down to 20% at 1 year and probably 10 to 15% at 2 years. There's this inexorable relapse month after month, year after year. So the notion that you could transfer dependence to a safe, much less harmful source of nicotine, which would then supplant the cigarette smoking, combustible smoking addiction, and that would be a lifelong replacement like methadone maintenance, does offer the hope that there would be a long-term protection against relapse. And some of the newer e-cigarette devices have protections against so-called dry puffing, where you can get high temperatures that start to produce the carbonyl compounds that people worry about, formaldehyde and so forth. So, e-cigarettes used under proper conditions have a tiny fraction of the toxins of cigarette smoke. So anyway, I think that should definitely remain part of the discussion.
Right.
Yep.
I had a question, and I can see the advantages of pre-quit treatment in terms of seeing what works before they try to quit. People have also talked about rescue treatment. So the idea of, any addiction and being a chronic, relapsing, remitting disorder of, when someone who's trying to quit lights up a cigarette, it's not a failure, but a stumble. And so preventing that stumble from getting into a full-blown relapse, what's known about that sort of kind of break the glass if needed for emergency?
Yeah. So Fiore, Mike Fiore's group up in Wisconsin did a nice study on that I was going to say a year ago, but I think it's actually a few years ago now. And what they did was they had two different, when a person lapsed, they had two different treatment approaches. One was to say, just go back to being quit right away. Just quit now. You smoked a few cigarettes, just stop it, quit right now. And the other was to say, okay, let's schedule a quit day. Let's get prepared. Let's kind of da-da-da-da-da. And it turned out that the just quit now approach was superior to the preparing. So it wasn't necessarily, and we've had some questions about this. What do you do when somebody lapses? Do you tell them to just get back on the wagon now, or do you kind of take a step back and prepare? And usually if a person, in my experience, if it's a lapse, you go very quickly. If it's a complete relapse, back to former smoking levels. And then a lot of times you do have to kind of go back to the drawing board and take another approach. I don't know if that speaks to that question. There was a kind of funny study looking at quit attempts, and this was done by I'm drawing a blank now. The cardiologist down at MD Anderson, and said that essentially showing that statistically speaking, each quit attempt really needs to be considered as a statistically independent event. That just because you failed in a particular quit attempt doesn't mean that you're going to fail at a second quit attempt, even if you're using the same medication. And
that's right. That I've seen that data as well. It's more like just Russian roulette in reverse, where it's a good thing if you can can quit. But the problem is that the average interval in between serious quit attempts for smokers is something like 2 or 3 years. So there is some sort of demoralization process that occurs, which would be wonderful to overcome. And then they could just keep quitting until they succeed. But, if it's sort of like asking a young person, teenager in their 20s, dating age, don't mind if you get rejected, asking someone out for a date, just keep asking and, 100 times and somebody's going to say yes, but people get discouraged and they won't typically do that.
Good. Sven, you had a question?
Yeah, it was fascinating to see these additive effects of bupropion and varenicline treatment at the same time. How does that work pharmacologically? Bupropion is an inhibitor of nicotinic receptors. Varenicline is a partial agonist. Is there anything known about if they hit different receptor population? How might that work?
So I'll give you a mechanistic understanding plus kind of my clinic understanding. So when you put somebody on varenicline by itself, varenicline is, as I'll say what we all know, but it's a very powerful, complete nicotinic agonist. It binds and blocks the receptor very well from nicotine and decreases reward very impressively. However, the stimulation of the nicotinic receptor is, looking at receptor binding studies, it looks like it's about 38% of what you get from nicotine. It's not very robust stimulation of the receptor. The main action of varenicline is blockade, and with relatively minor stimulation. What that means is that it's very common, and this is the clinical part of it, for me to put somebody on varenicline, for them to have a big response to smoking, ostensibly related to a loss of nicotinic reward. They get on the drug, it's not rewarding to smoke, and they suddenly smoke much less, and they throw themselves into withdrawal. They're essentially exhibiting withdrawal symptoms even before they quit, because it's no longer rewarding, and they're smoking less. And when I'm thinking about adding bupropion or nicotine patch, I'm thinking about adding a medication that increases neurotransmitter levels that are low during withdrawal. That with bupropion, you're increasing dopamine and norepinephrine, and providing some relief to that withdrawal. And so I actually, the way I think about nicotine patch is with somebody who has significant receptor upregulation, and they've only bound some subpopulation, some portion of the nicotinic receptors, and there's still unbound receptors that are available for the nicotine patch to bind and really give much more substantive stimulation and to control withdrawal. Now this is this is trying to put together a clinical picture with my limited understandings of neuroscience, but it is they do actually work pretty well together. Because one's primarily blocking and one's primarily, providing withdrawal.
And just to add one nuance to that, which I think what you present is a plausible hypothesis for sure. Because bupropion does have both actions. It does block reuptake of dopamine, and through its metabolites also norepinephrine. So you're raising those levels of neurotransmitters. But bupropion also directly blocks nicotinic receptors. But then so does varenicline. But one other thing that varenicline does, in addition to being a partial agonist with, as you say, perhaps more antagonistic effects than agonistic effects at the most prevalent receptor subtype alpha 4 beta 2, but it's also a full agonist at alpha 7 nicotinic receptors, and we still do not know how important those effects are for its actions. And there's a lot of work about the role of alpha 7 nicotinic receptors in schizophrenia, and we also all know that the highest rates of smoking occur in people with schizophrenia and other mental disorders. So I think there's a lot of mysteries still in these mechanisms of receptor subtypes, but certainly how you explained it, I think, is a good starting point.
Great. Well, thanks. Wonderful presentation and great discussion. It's right on 3 o'clock now, so I know people have other things they need to go to. But thanks again, James, for your presentation. I appreciate that. We should really continue this discussion. I just want to remind people, February 9th is our next seminar. It's going to be live at the DIBS facility, and it'll be Joyce Bashir from University of North Carolina talk about the interaction between stress and drinking and PTSD and animal model. Okay, thanks a lot.
Will there be a happy hour after?
Thanks, everybody. Thanks, Ed.
Thank you. Bye.
Thanks, James. Well done.
Thanks, Chad.